My dear students, in this video, I am going to discuss about the recently published multidisciplinary guidelines about renal replacement therapy in the ICU. And I will also try to differentiate or to find out the subtle differences from the Indian guidelines that was published by ISCCM and that came in the Indian Journal of Critical Care Medicine in 2022. Now, this is a multidisciplinary guideline which was published in the January edition of Critical Care. And this multidisciplinary guidelines are important because it recounted the experiences and the opinion of different specialities besides intensive care and nephrology and urology. And therefore, we have to look into it from a wider kaleidoscope. So these guidelines, which were published in 2026 January, were developed by using systematic literature review, Delphi consensus, and grade methodology by an expert panel of intensivists, nephrologists, and multidisciplinary clinicians. And the guideline focuses on 7 key domains. 1, the timing of initiation. 2, diffusion versus convection. 3, continuous versus intermittent modalities. 4, anticoagulation. 5, dose prescription. 6, pharmacotherapy during RRT. And the 7th or the last is the weaning or stopping criteria. Now, going to the first domain, when to start RRT. The absolute indications in this, according to the guidelines, in which RRT needs to be started immediately are only few: life-threatening hyperkalemia, severe metabolic acidosis, fluid overload with pulmonary edema, and uremic complications like encephalopathy. There are relative indications like for non-life-threatening abnormalities, which includes conservative management and close reassessment in these indications. And biomarkers alone should not trigger initiation of renal replacement therapy. Elevated creatinine or urea without symptoms may not require immediate dialysis. And this was because of important trials like the START AKI trial, which show that early initiation does not consistently reduce mortality, and some delayed groups never required RRT at all. Therefore, the clinical trajectory, the comorbidities, and the severity of illness is something that should guide and prompt decisions, and the clinicians, the nephrologists, and the intensivists should adhere to those trajectories and severity illness. The next domain which was highlighted in this guideline was that diffusion between convection, the difference between diffusion versus convection. The diffusive therapies, we know hemodialysis. The convection, we know hemofiltration, or we know that there is combined technique of hemodiafiltration. Now, all this shows similar outcomes. Convective therapies may clot filters earlier because of hemoconcentration. If we go indication-wise, in severe hyperkalemia, diffusion with high dialysate flow is preferred because potassium removal is faster. In rhabdomyolysis, RRT should not be started solely for myoglobin removal unless AKI indications are also present. And in sepsis, there is no outcome benefit of convection despite theoretical cytokine removal. So we can say that the new guidelines say that choose modality based on logistics, expertise, and patient goals, not on the basis of theoretical superiority of one over another, because there is none. The third domain that is discussed is the continuous versus intermittent renal replacement therapy. We know that there are 3 major options exist, and all 3 options have been highlighted in the current guidelines: the CRRT, the IHD, and the SLED. The mortality and recovery, if we see, for the large reviews shows no consistent mortality difference between CRRT and intermittent hemodialysis, and observational data suggest possible renal recovery benefit with CRRT, but RCTs are inconclusive. When hemodynamic instability is an issue in ICU, the CRRT or prolonged therapies are preferred because they cause slower fluid removal, they cause less hypotension, and they have lower vasopressor requirements. In neurocritical care patients, because rapid osmotic changes during intermittent dialysis can worsen intracranial pressure, so it is the guidelines say to use individualized prescriptions and avoid rapid shifts in sodium or osmolality. So indirectly, this is also a situation where CRRT may be beneficial. In terms of fluid overload, the guideline says that all modalities can achieve negative balance and the success depends more on prescription than modality. On mobilization, it says that the CRRT should not prevent early mobilization when proper protocols are implemented. And it summarizes that in stable patient, any modality is acceptable, while in unstable brain or circulatory shock patients, hemodynamically unstable patient, probably it favors continuous or prolonged therapy. The fourth domain is the anticoagulation during RRT. And in that case, there is a big difference because regional citrate anticoagulation has been highlighted strongly in the 2026 guidelines because it has comparable patient outcomes versus heparin. It has longer filter life and it causes fewer bleeding complications. So whenever there is high bleeding risk or heparin contraindication, regional citrate anticoagulation, the reducir that we use, should be preferred. The concerns with citrate are that we need to monitor for hypocalcemia, metabolic alkalosis or acidosis, and also citrate accumulation, particularly in patients who are on severe shock or in liver failure. But liver failure is not an absolute contraindication, but it is a close monitoring is necessary when regional citrates are used. Regarding heparin strategies, unfractionated heparin is preferred over low molecular weight heparin because of easier monitoring, and argatroban is an option for HIT type 2. So, according to these guidelines, the RCA is increasingly the first line in modern CRRT, provided monitoring exists in the infrastructure. Regarding next is the dose of RRT, the continuous therapies, the recommended dose as per the guidelines is the same 20 to 25 mils per kg per hour effluent, and the higher doses of 35 to 40 mils per kg per hour, they do not improve survival but increases the adverse effects like the hypophosphatemia. In intermittent therapies, the dose is determined again by the blood flow rate, dialysate flow, session duration, and the clinical targets, the electrolytes and the acid-base status. Always avoid dialysis disequilibrium syndrome by gradual correction. So don't attempt prompt or sudden severe correction. In high volume hemofiltration, there is no clear benefit in sepsis and it is not recommended routinely as per the 2026 guidelines. So the dose of RRT or the adequacy of the dose of RRT depends upon the consistent effective delivery. It does not depend on the maximal intensity of the renal replacement therapy. And that's what has been highlighted. Pharmacology during RRT, this is again one area on which a lot of recommendations have been emphasized. The loading dose should not be reduced and it should be based on the volume of distribution, which is often increased in the ICU because of edema or hypoalbuminemia. Regarding maintenance dose, it depends upon the residual renal clearance, machine clearance, the drug characteristics, and hydrophilic drugs like the beta-lactams, vancomycin, they are heavily affected by the RRT. Regarding continuous versus intermittent infusion, for time-dependent antibiotics, prolonged or continuous infusion may improve the target attainment and of those drugs. And evidence is limited in RRT patients, but pharmacologically it is logical. What about therapeutic drug monitoring? This has been recommended for beta-lactams, aminoglycosides, vancomycin, because TDM improves the PK/PD target attainment, but the mortality benefit remains uncertain. So in renal replacement therapy, the guidelines stress the fact that underdosing of antibiotics is more common than overdosing early in the course of therapy. And the last is about the stopping RRT or the weaning. According to these 26 guidelines, the discontinuation should be considered when absolute indications have resolved and the endogenous kidney functions improves. So some predictors of successful weaning is an increasing urine output of 300 to 600 ml per day, which suggested guidance, and improving acid base and electrolytes with stable fluid balance. And the warning signs of failure include persistent hyperkalemia, metabolic acidosis, ongoing fluid overload, and most studies define successful discontinuation when there is no need for RRT for 7 days. So, weaning is a trial of kidney recovery and therefore needs close monitoring. If you look into the Indian guidelines, the IGCCM guidelines, which was the ISCCM guidelines, which was published in IGCCM in 2022. So the method adopted was consensus driven. Here in 2026, this multidisciplinary guidelines have gone for grade and Delphi consensus. The evidence grading was extensive this time. It was moderately high in the Indian guidelines of 2022, and the applicability was high resource ICUs in the 2026 guideline, and in 2022 it is the variable resource ICU. So probably the generalizability of the IGCCM 22 guidelines is better, if not the method and the evidence grading. And this IGCCM 22 guidelines looked for broader AKI plus renal replacement therapy guidance, which can be adapted for Indian ICUs. And it included prevention, nutrition, hardware, ECMO integration, toxicology, as well as the practical logistics. And it was designed for variable source settings and multidisciplinary use. Now, biggest conceptual change, if you see from then and now, is the timing of initiation. There is a strong shift towards clinical context. In immediate, RRT is only recommended in these four conditions: hyperkalemia, acidosis, overload, and uremia. The biomarkers are creatinine elevation alone, no. Negative furosemide stress test trigger, no. Early RRT does not improve mortality consistently. So this has been the hallmark of 2026 guidelines. And the difference is that in 2022, the stance was more neutral, and the 2026 points to very strong anti-lab triggered initiation, either based on creatinine biomarker, etc. Regarding the continuous versus intermittent modalities, the simpler recommendation for bedside use was there in IGCCM or ISCCM 2022. It is seen now that it is almost the same, but CRRT is preferred according to the current guidelines in hemodynamic instability, in raised ICP, in neuro ICU, with focus on osmolality shifts rather than the modality itself. Regarding diffusion versus convection, 2026 gives stronger, no superiority, evidence-based clarity. In 2022, the IGCCM guidelines discussed modality options, but less detailed comparative evidence, and it was more hardware focused rather than mechanistic. But in 2026, it is more mechanistic focus. If you look into the anticoagulation in 2026 guidelines, it is highly detailed because regional citrate anticoagulation, as it says, has equals outcomes versus heparin, causes less bleeding, has a longer filter life, and the liver failure is not an absolute indication for an absolute contraindication for regional citrate. So it has strong monitoring emphasis. In contrast to IGCCM 22, it mentions the anticoagulation strategies with practical approach for Indian ICU setups, but it didn't go deep into the citrate metabolism nuances that the 2026 guidelines does. Regarding the dose of CRRT, both guidelines agree that the CRRT dose of 20 to 25 ml per kg per hour effluent is sufficient, and high intensity CRRT has no survival benefit. Pharmacology therapy again is one area on which a lot of emphasis has been given in this 2026 multidisciplinary guidelines. Very advanced, loading dose should not be reduced, PKPD driven dosing, emphasis on volume of distribution changes, machine clearance, and with encouragement on TDM for beta-lactams, vancomycins, and aminoglycosides. The IGCCM 22 guidelines only mentions the drug dosing principles and puts much less pharmacokinetic detail in comparison to the recent guidelines. So this has been one of the biggest upgrades of 2026. With regard to stopping the renal replacement therapy, 2026 guidelines gives a detailed weaning criteria again with 300 to 600 ml per day guidance and defines successful discontinuation of 7 days of non-requirement of renal replace therapy. The Indian guidelines of 22 discusses weaning, but it is a less structured criteria and it gives more narrative guidance. So my take home message after reading the current guidelines as against the Indian guidelines of 2022 is that there has been a conceptual evolution from 22 to 26. The timing has shifted from early versus late to clinical trajectory guided. The number of absolute indications has reduced. There has been a stronger rejection of lab only criteria, not looking into the physical or the clinical condition of the patient. That has been strongly disregarded. Expanded RRT pharmacology, a lot of stress on the loading dose, the PKPD guided dosing, as well as therapeutic drug monitoring. More precise anticoagulation, the citrate physiology has been studied and explained in detail with focus on regional citrate anticoagulation. And there has been a greater focus on individualized prescription and weaning rather than a thumb rule approach. Thank you.